I believe you can now see the. I believe you can now see the PowerPoint, right? So what we are going to see today is the cardiac pharmacology. Okay, so this is a super important area. Majority of the questions related to the pharmacology is going to ask from this cardiac region. Okay, so you have any doubt? Kindly cut me through and ask the question. Okay, so first drug is the cardiac glycoside. Okay, kindly write the lecture notes in between. Okay, so cardiac glycoside is the first drug. Cardiac glycosides examples are digitalis, digoxin. All those things are cardiac glycosides. Now, before moving into that, we must understand what is the function of this digoxin as well as digitalis. What it is, what it does to the body. Okay, so first thing, it produces a positive ionotropic effect. Okay, it produces a positive ionotropic effect. All these points are very important. Okay, it produces positive ionotropic effect. Now, what do you mean by a positive ionotropic effect? A positive ionotropic effect means it increases the force of contraction of the heart. Okay, when I say the cardiac glycosides produces a positive ionotropic effect, the ionotropic effect means it increases the force. It increases the force of contraction of the heart. The pumping, the force, see, it's different. It is not the rate, it is the force of contraction. Okay, a positive ionotropic effect means it increases the force of contraction. Now, how it increases the force of contraction? It increases the force of contraction by increasing the permeability of cardiac muscles to calcium as well as sodium ions. Okay, we know we have studied the tissues, we have studied the cell. You know how the ions enter into the cell, how the calcium enters into the cell, right? So when an iron, when a sodium enters into a cell, the potassium goes out of the cell. Likewise, when a calcium enters into a cell, the magnesium goes out. Okay. So what do you mean by a positive ionotropic effect? A positive ionotropic effect is nothing but it increases the force of contraction. Ionotropic means force of contraction. A positive ionotropic means a positive or an increased force of contraction. How the force of contraction is increased by the heart? By increasing the permeability of the cardiac muscles. It will loosen the cardiac muscles so that the calcium as well as the sodium enters into it. Clear? So that is a function of this cardiac glycoside. It increases the force of contraction. Clear? That is the main point. It increases the force of contraction. Now, when the force of contraction is increased, when the force of the heartbeat is increased, it increases the cardiac output. Okay. So, thus it increases an effective heart pumping. So, cardiac glycosides are given to increase the cardiac output. Okay, so the patient who are having the ejection fraction with 30, 40, 50. So in those conditions, in those patients, we'll give digoxin or digitalis. Clear? And one more thing, what is the normal range of digoxin, serum digoxin level? See, the normal range of serum digoxin level is zero point 0.9 to 2 nanogram per milliliter. That is a normal serum level of digoxin. Okay. More than 2 grams is the toxic level of digoxin. Kindly note, in some textbook, it is written as 1.9 also. Okay. Because 2 and above is considered as toxic. That's why. So I still remember when I have went to write the MSc nursing exam in AIMS. So this was the first question: what is the normal serum toxic level of digoxin? So the normal serum level is zero point 0.9 to 1.9, whereas 2 and above is the toxic level. Okay. So that's about the serum digoxin level. Okay. So once again, when we are giving the cardiac glycoside, that is the digoxin or the digitalis, it increases the positive inotropic effect. Which what do you mean by that? It increases the force of contraction. So when the force of contraction is increased, the the cardiac output will be increased. Now, second point, it produces negative chronotropic effect. So chronotropic means rate of contraction. So when it is a negative chronotropic effect, it decreases the rate of contraction. Okay. So uh, first thing, it increases the force of contraction. Second thing, it decreases the rate of contraction. Clear? What was his first action? It increases the force of contraction. What is its second action? It decreases the rate of contraction. So if a patient's heart rate is 70 or 80, it will be decreased to 50 or 60. Okay. It stabilizes, it decreases the heart rate. Even though it decreases the heart rate, it increases the force of each beat so that the cardiac output is increased. Okay. Now, now in which conditions we give these cardiac glycosides? First thing, it is given for the heart failure. Okay. It is given for the heart failure. Then atrial flutters, atrial fibrillations. Okay. AF, fibrillation, atrial flutters, we'll give the cardiac glycosides. Now, an ECG, an ECG of atrial flutter. Okay. Atrial flutter is a sawtooth ECG. Kindly note that this it is a sawtooth ECG. Sawtooth, sawtooth ECG. Okay. Next, atrial fibrillation. In atrial fibrillation, QRS complex. The P wave, you won't be able to identify the P wave. They're like fibrillating P wave. To be precise, this is the P wave which is followed by a QRS complex, right? So what happens at the time of P wave, there will be fibrillating. Then we can have a QRS complex followed by a T wave. Then again, it will be fibrillating. You will be having a QRS complex, a T wave, a fibrillation, then a P wave, QRS complex, a T wave, then again a fibrillation, QRS complex, T wave. See, this is atrial fibrillation. It will be fibrillating. P wave will be fibrillating like this. Okay, clear. See, you are able to see the T waves here because this AF, this atrial fibrillation is normal rhythm. Okay, it is not having a tachycardia. Usually, if a patient is having a normal rhythm atrial fibrillation, it is not a medical emergency. But if a patient is having a tachycardic atrial fibrillation, it is a medical emergency. Clear? And flutter is definitely a medical emergency. Sawtooth ECG. Clear? So we have now understood AF as well as flutter. And this ventricular tachycardia is nothing but like this. See, this is the ventricular tachycardia, the ECG of a VT. This is the ventricular tachycardia. Okay. Now, what are the main side effects? Okay, what are the main side effects of these drugs? The main side effects of any drug is nausea, vomiting, diarrhea. Okay. Apart from that, apart from that, we can have a bradycardia. Okay. Why a bradycardia? Because of this negative chronotropic effect. Okay. You can have a bradycardia because of its chronotropic effect. Okay. Now, toxicity. This is important. The cardiac glycosides toxicity. You can see PVC, premature ventricular contractions. In ECG, you can see premature ventricular contraction. See what you mean by premature ventricular contraction is, see this is the ECG is coming on a normal pathway. then suddenly you can see this type of ECG. Then it will be normal. See, so this pattern is known as a premature ventricular contraction. Okay, or VPC, ventricular premature contractions. Both are same. Got it. Premature ventricular contractions. Next toxicity. It can be xanthopsia. Xanthopsia. Xanthopsia is a yellow vision. Okay, this is yellow vision. This is a yellow vision. Then you can also have a blurred vision. Blurred vision. It again causes neurotoxicity. Neurotoxicity. It may cause hypokalemia. Okay, it causes hypokalemia. So in the nursing management, what do you have to do in the nursing management? You have to check all the toxicities. Okay, and ECGs, you have to check the ECG for the hypokalemic status. Hypokalemia. See how you can see the hypokalemia in ECG? There will be depressed T wave. T wave will be depressed in case of hypokalemia. And you have to check the serum digoxin level. Zero point 0.9 to 1.9 is the nanogram per ml. Okay, nanogram per ml. This is the normal digoxin level. I hope cardiac glycoside is clear to you. Okay. Next, we move on to the antiarrhythmic drugs. You know arrhythmias, right? What is an arrhythmia? Any abnormalities in the rate and rhythm of the heartbeat is known as an arrhythmia. It is dysrhythmias. Any disturbance in the rhythm is known as arrhythmia or dysrhythmias. Okay. So it is these anti-arrhythmic agents are given to treat the abnormal variations in the pulse and prevent these dysrhythmias. Okay. Now we have some sort of drugs. We have classified those things. So the classification of drug antiarrhythmics. So class 1, 2, 3, 4, those are the classifications of antiarrhythmic drugs. Okay. We have been classifying these drugs into class 1, 2, 3, and 4. Now, in the class 1, the class 1 is again divided into class 1A as well as class 1B. Okay. No, what is a class 1A drug? So class 1A drugs suppresses the ectopic foci. So what is an ectopic foci? See, usually the heart, which is the pacemaker of the heart, the SA node is the pacemaker, right? When the SA node is not functioning, when the SA node is not producing the impulse, the AV node can be the AV node can produce an impulse. The bundle of his can produce an impulse. Even the Purkinje fibers can also produce impulse. Okay, so any beat which is produced apart from an SA node is known as an ectopic foci. Okay, ectopic means anything apart from the original area. Like, what is an ectopic pregnancy? So ectopic pregnancy means a pregnancy which is not involved or which is not present in the uterus. It can be in the fallopian tube, it can be in the ovaries, it can be in the abdomen, any area, it can be in the vagina, it can be in the cervix, any area apart from the uterus. So ectopic means anything which is apart from the original place. Okay. So the class 1A drugs, these drugs will suppress these ectopic foci. Okay. So if your SA node is not functioning, suppose your AV node is producing the AV node is producing your heartbeat. So when the AV node is producing your heartbeat, how you can identify in the ECG? It's a junctional rhythm, right? So there won't be P wave. The atrial contraction won't be there. Clear. So it's a junctional rhythm. It's just your P wave will be absent, whereas the QRS as well as the T will be normal. Right. So that condition is known as an ectopic foci. So in that particular ectopic foci, we'll give this class 1A drugs. Okay. Now, how it is suppressing this ectopic foci? It is suppressing this ectopic foci by increasing the refractive period and slowing the depolarization. So, what is depolarization? Contraction. It will slow the contraction. Okay. Just understand like this: class 1A drugs will suppress ectopic foci. This is enough. It suppresses the ectopic foci. Can you give me the example for class 1A drugs? Anybody? It is quinidine, then procainamide. Okay, those are the antiarrhythmic drugs. Quinidine, procainamide. Kindly write it down. Quinidine as well as procainamide. Then second one is class B drugs. Okay, see this class B drugs suppresses the ventricular arrhythmias. Okay, so class 1B drugs mainly focus on the ventricular arrhythmias. Okay, so in the ventricular arrhythmias, how it act on the ventricular arrhythmias? It decreases the automaticity and increases the electrical ventricular electrical stimulation threshold. Just leave that. Just understand that it acts on the it suppresses the ventricular arrhythmias. The drugs are lidocaine, are lignocaine as well as then phenytoin. Lignocaine as well as phenytoins are the drug of choice for class 1B drugs. So class 1 is clear, right? So first thing, it suppresses ectopic foci. Second thing is for ventricular arrhythmias. So the drugs were the quinidines as well as the procainamide and the lignocaine as well as the phenytoin. Okay. And there is one more drug in the class 1B. Okay. It slow it slows the contraction. Flecainidine, just leave it. This lignocaine and phenytoin is enough. Just leave it. Next is class 2 drugs. Class 2 drugs are the beta blockers or the beta adrenergic blockers. You might have heard about these beta blockers, right? So the beta blockers are antihypertensive medicines also. Beta blockers or the beta adrenergic blockers. The atenolol, propranolol, metoprolol, all these things are the beta blockers. Okay. And what is the function of this? See, it will decrease the BP. That's why it is given as an antihypertensive drug also. But it is having an anti-arrhythmic effect. It decreases the heart rate. Okay. It decreases the heart rate. The beta blockers will decrease the heart rate and decreases the myocardial load and oxygen requirement. Okay. It decreases the heart rate and it decreases the myocardial load and oxygen requirement. Clear, these beta blockers. That's why it is used to treat tachyarrhythmias. So arrhythmias in which there is tachycardia. Okay, that is tachyarrhythmias. So it is used to treat the tachyarrhythmia, hypertension, and angina pectoris. See, when you check a patient who is having simply we can say that if you are checking a patient and his heart rate is 110, 120, and he is having a BP of 170 per 100. So which drug you can give? You can simply give these beta blockers because it will decrease the BP and also it will decrease the heart rate. Okay. And if you're seeing a patient with BP of 170, and the heart rate around 55 to 58, will you give these drugs? No. At that particular point, you are not supposed to give those drugs. Why? Since the patient is in bradycardia, already the patient is in bradycardia. When we give these beta blockers, it will again decrease the heart rate. Okay. That's about the class 2 beta blockers. Second one is class 3 drugs. It will prolong the repolarization. What is repolarization? The relaxation. So it will increase the relaxation period of the heart. Example, Amiodarone. Amiodarone is an example for class 3 drug. Okay. It increases the repolarization. Again, if there is if a sinus tachycardia also. See, what is sinus tachycardia and what is a sinus tachycardia? Sinus tachycardia means rate is increased but rhythm is stable. Okay, a sinus tachycardia, the rate is also increased, the rhythm is disturbed. Okay, so that is the function of amiodarone. It will prolong the repolarization. Next, class 4 drugs, the calcium channel blockers. Again, the calcium channel blockers are given for what? These class 4 calcium channel blockers are given as an antihypertensive drug also. Okay. What the name itself indicates, it blocks the calcium which is going into the muscle. So, do you remember the medicine which allows the calcium to go into the muscle? It was your cardiac glycoside, right? So the cardiac glycosides, the digitalis as well as the digoxin, will increase the cardiac muscles for calcium, whereas the calcium channel blockers will obstruct the movement of calcium into the muscles. Okay, so be cautious when you're giving the digitalis as well as calcium channel blockers. Both of the drugs are having an opposite action. Okay, so we won't give these calcium channel blockers along with the digitalis. So the calcium channel blocker will block the calcium which is entering into the muscles of the heart. Okay, and it is also an antihypertensive drug. Amlodipine, diltiazem, verapamil, those are the calcium channel blockers. Amlodipine, diltiazem, verapamil. Okay. Now, what are the main side effects of these things? The main side effect of these drugs are the main side effect of these drugs are they causes hypotension. Why? Because all of these things are acting on are the drugs which is given for hypertension, right? So the main side effect is it causes hypotension. It may cause heart failure because it decreases the contractibility of the heart. There is a chance for heart failure. Next, it may leads to blood dyscrasias. What is blood dyscrasias? It is nothing but it will decrease the RBC, WBC, and platelet synthesis. When I say dyscrasias, it decreases the RBC, WBC, and platelet synthesis. Okay, that is the main side effect of these drugs. Now, next, third classified drugs are cardiac stimulants. Okay, we'll give these drugs to stimulate the cardiac muscles. What are the function of these drugs? Tropin, epinephrine, isoprolol. So all these drugs increases the heart rate. Okay, it act on the autonomous nervous system. What about atropine? Atropine will increase the heart rate and decrease the vagal stimulation, and it also decreases the parasympathetic nervous system at SA node as well as AV node. Just leave all those things. Atropine will increase the heart rate. Epinephrine, which is the adrenaline as well as epinephrine, both increases the heart rate and the force of contraction. Okay. And what are the main side effects? There will be tachyheadache. See, when we are giving a cardiac stimulant and if we are feeling a headache, that is due to a dilation in the cerebral vessels. Okay, the cerebral vessels are dilated. That's why you are having an headache. Okay, and next side effect is kindly put this side effect test star mark. It is an anticholinergic effect. Anticholinergic effect. You will hear multiple times the word anticholinergic effect. So anticholinergic effect. What do you mean by this anticholinergic effect? In the anticholinergic effect, you will be having dry mouth. Okay. Dry mouth will be the blurred vision will be the urinary retention. Okay, this is anticholinergic effect. Okay. There will be dry mouth, blurred vision, and urinary retention. That is because of your parasympathetic nervous system is depressed. Okay, this drug will increase in depression in the parasympathetic nervous system. Dry mouth, blurred vision, as well as urinary retention will be there. That is cardiac stimulants. Clear. Next is coronary vasodilators. So coronary vasodilators means the blood which is going into the heart muscles are the coronary arteries, right? So we are giving these drugs to dilate these coronary blood vessels so that more blood is moved into these coronary arteries. So what might be the reason? There will be a clot in the coronary arteries. So in order to push the oxygen towards the cardiac muscles, we give the coronary vasodilators. So if a patient is having an angina pectoris, we'll give coronary vasodilators. What is the drug? It is our nitrates, isosorbitol dinitrate, the drug which we'll be keeping under the tongue. It's a sublingual drug. So what happens when we are taking these drug? These drug will dilate the coronary arteries. Okay. So it will act on the smooth muscles of the coronary arteries and it increases the vasodilation. Isosorbitol dinitrate. Okay. And it also decrease the cardiac workload and oxygen requirement. It's act on the preload as well as the afterload. Okay. Preload is just before the contraction. Afterload is just after the contraction. See, the main side effect when given these coronary vasodilators is that, believe me, in my experience, I have seen many patients when we give these patients vasodilators sublingually, the patient will be having a sudden drop in the blood pressure. Okay. So if a patient is having even I have seen a patient recently, I have seen a patient in the emergency department who was brought to the casualty with the complaints of chest pain. It was severe chest pain. The patient was on MI. It is a STEMI, and the BP is 180 over 100. And when we have given a 5 mg of uh, dinitrate, this nitrate, after what 10 or 15 minutes the BP have suddenly fall, and therefore the BP was 80 by 60. So the such kind of dramatic change can also be happened in case of dinitrates. So see, in some conditions we can't say that we won't be giving the dinitrate. Definitely we have to give the dinitrate, the nitrate. So what is the nursing management then? See, when we give the dinitrate, we have to closely monitor the blood pressure of the patient. Okay. And see, as a side effect, this is the side effect, the main side effect. There will be hypotension. Again, there will be tachycardia. Okay, the main thing is what we have said is a hypotension. Definitely, they'll be having an orthostatic hypotension. So we'll just keep the patient lying down the bed. When the patient stands, definitely there will be a hypotension. Why? Because all the blood vessels will be dilated. Specifically, the cerebral blood vessels also will be dilated. That's why the patient who with these nitrates will feel a headache as well as flushing. Headache is because of the dilation of the peripheral blood vessels, and flushing because of the vasodilation on your peripheral blood vessels. Headache on the cerebral vasodilation, whereas the flushing on the peripheral vasodilation. Okay, and it have to be kept in the amber glass container. These medicine should be kept in the amber glass container. Otherwise, what happen? It may react with the sunlight. Okay, then see, if a patient is complaining about a chest pain, you have given an uh, isosorbitol dinitrate. After 2 to 3 minutes, patient is saying that there is no change in the pain. you can give one more. Okay. Again, the patient is complaining after 5 minutes. There is no decrease in the chest pain. You can again give one more. The point is, it should not be exceeded 3 in 15 minutes. In 15 minutes, you should not exceed 3 drugs. That is 15 mg. Okay. So usually it comes in 5 mgs as well as 10 mgs. So that's about the coronary vasodilators. Next one is the antihypertensive drugs. Which are the antihypertensive drugs? First one is AC inhibitors. What is AC inhibitors? It is angiotensin converting enzyme inhibitors. Okay. So what is an angiotensin converting enzyme? See, the angiotensinogen have to convert into active angiotensin, then only the BP will be increased. Okay. So what is the drug does? The drug will uh, inhibit the angiotensin converting enzyme. See, the angiotensinogen have to be converted into angiotensin. There is an enzyme present there to convert the angiotensinogen into angiotensin, right? So this drug will act on this angiotensin converting enzyme, and it will inhibit the function of the angiotensin converting enzyme so that no active angiotensin will be formed. Thus, it decreases the blood pressure. Okay, AC inhibitors. Anybody know the drugs? It is captopril, enalapril, ramipril. Okay, AC inhibitors. Captopril, enalapril, ramipril. Those are the drugs of AC inhibitors. Second drug is angiotensinogen 2 receptor blockage. See, it's same as the AC inhibitors. The main function is same as the same how the AC inhibitors are functioning, but it is likely to cause chronic cough. That is the main difference between angiotensin 2. It is likely to cause chronic cough. So, if a patient with bronchial asthma or if a patient with a respiratory distress, we won't give AC inhibitors, but we'll go with angiotensin 2 receptor blockage. That is the losartan. Okay, valsartan, losar, the famous losar 50, losartan as well as valsartan. Those are the group of angiotensin 2 receptor blockages. Third one is the calcium channel blocker. So we have seen which are the calcium channel blockers, right? Amlodipine, nifedipine. And see, the calcium channel blockers, mainly the amlodipine. If a patient is taking the amlodipine for a particular longer period, there is a chance for developing pedal edema. Okay, both legs there will be edema, and it will be pitting one. Okay, pitting edema is the side effect of amlodipine or the calcium channel blockers. Next is diuretics. So what is a diuretic? A diuretic is a thing which increases the uh, what the urine out production, or it will help the body to remove the excessive urine. Diuretics. What is the main diuretics that we know? We use is Lasix, right? So Lasix is a loop diuretic. It decreases the sodium and water reabsorption. So it increases the urine output. Lasix, it's a loop diuretic. Next diuretic is an potassium sparing diuretics. So potassium sparing diuretics means in case if a patient is having an hypokalemia, we doesn't want to lose the potassium of for that patient, right? So the patient will be having hypertension and also the patient will be having hypokalemia. So in order to decrease the blood pressure, we have to give uh, these diuretics, right? So we have to also save the potassium. That's why we'll give the potassium sparing diuretics. Spironolactone or the aldactone is the drug of choice. Next is thiazide diuretics. So what is a thiazide diuretic? These thiazide diuretics inhibits the carbonic anhydrase activity at the distal tubular site. So we have proximal convoluted tubule, distal convoluted tubule. If you remember the what the nephron, you'll be able to answer this. See, this is the loop of Henle, Henle's loop. Lasix will act on this. Lasix will act on this. Whereas the the thiazide diuretic will act on the distal tube. Okay. The thiazide will act on this distal tube. Hydrochlorothiazide, that is a drug. The thiazide diuretic. Hydrochlorothiazide, that is a drug. So again, uh, we have an osmotic diuretic. Again, we have an osmotic diuretic, which is the mannitol. Mannitol, the osmotic diuretic. Okay. Now, the diuretics, there is some nursing management in the diuretics. See, in potassium sparing diuretics, there is a chance for developing hyperkalemia. Okay. And Lasix, when Lasix is given with the aspirin, it causes toxicity. Kindly note this point. The Lasix Lasix, when given with aspirin, it causes toxicity of the aspirin. And when the thiazide diuretics as well as the loop diuretics causes hyperglycemia in diabetes patient. The thiazide as well as the loop diuretics causes hyperglycemia in diabetes patients. Okay. Fifth drug is the beta blockers. We have seen the beta blockers, right? Sixth drug is the alpha 1 blockers. See how the beta blockers were functioning. Likewise, we have the alpha 1 blockers. See, we have alpha 1 blockers, alpha 2, alpha 3, such kind of blockers are there. Okay, the alpha blockers. Okay, the alpha, specifically the alpha 1 blockers, will decrease the effect of norepinephrine. Okay, by blocking the receptors at the vasomotor tone controlling system. So simply understand that the alpha blockers will decrease the effect of norepinephrine. The drugs are minipress XL, prazosin. See, these alpha 1 block drugs are mainly given for CKD patients. There are chronic uh, kidney disorders. See, the hypertension must have affected the kidneys also. In those conditions, minipress XL as well as prasosins are given. Seventh drug is your alpha beta blockers. Levitalol. Okay, levitalol is given for an emergency uh, BP patient. So if the BP is very high, about 200 bar 120 or 100, we'll give levitalol. It's an alpha beta blocker. So the levitalol will cause vasodilation and decrease in the heart rate. Cardividol also. Levitalol, like cardividol, it causes vasodilation and decrease in the heart rate. That is alpha beta blockers. Next is central alpha 2 agonist. Central alpha 2 agonist. Are clonidine, the methyl dopas are the example. It will decrease the sympathetic nervous system. That's a function. Then the direct vasodilators. Nitroprusside sodium. Yes, direct vasodilators. Nitroprusside sodium. It relaxes the smooth muscles of the arteries. Okay. And decreases the peripheral vascular resistance. That's a function. It acts on the smooth muscles of the arteries. Nitroprusside sodium. Okay. Now, the next drug is if you are having a hypotension, we can go with the dopamine. Okay. If you're having hypotension, we can give with the dopamine drips. Now, anticoagulants. What are the functions of these anticoagulants? The anticoagulants will prevent the fibrin formation, clot formation, and it also prevent the platelet aggregation. Okay, fibrin formation, it will prevent the fibrin formation as well as it prevent the platelet aggregation. The drugs are a heparin. What is the antidote? It is protramin sulfate. Then low molecular weight heparin, warfarin. Warfarin is otherwise known as comedin. Okay, vitamin K is the antidote of warfarin. Warfarin is otherwise known as comedin. And what are the main side effects? See, as you know, it is an anticoagulant, so it causes hemorrhage. As a side effect, it causes hemorrhage. Then petechiae. What is petechiae? Petechiae are pinpointed bleedings on the skin. So it's a pinpointed red colors which you can see on the skin. Those are petechiae. Then it may leads to bruising. What is a bruising? So bruising again, and peripheral bleeding is a bruising. Tinnitus can happen. Okay, tinnitus means a ringing sensation. See, the aspirin, it's a main complication of the aspirin, loss of hearing. Okay, overdose of aspirin will leads to loss of hearing. See, as a nursing management, you have to check the therapeutic PT, APTT, INR values. Okay, the INR value is around therapeutic INR value is around 2 to 3.5, whereas a therapeutic activated prothrombin time is APTT is 1.2 to 1.5 to 2. Okay, INR value is 2 to 3.5, whereas APTT is 1.5 to 2. And also you have to avoid giving IM injections when when the patient is on anticoagulants. Why? Because there is a chance for bleed. Next, the thrombolytic agents. Thrombolytic agents means you see if we are seeing that there is a STEMI for the patient, so we'll thrombolize it. Okay, so usually this was the management previously, but now what we'll do if we are seeing a STEMI or if we are identifying a patient with MI, we'll go for coronary angiogram and angioplasty. Okay, so streptokinase as well as urokinase were the drugs which were used in the thrombolysis. Okay, and what is the main side effects of the thrombolysis? There will be bleeding. Okay, GI bleeding was the main complication. Anti-anemic drugs. Next classification is anti-anemic drugs. So a patient with uh, CKD, so his the functions of the kidney will be impaired, and one of the main function of the kidney was for the colony stimulating functioning for the production of blood cells. So when the kidney have shut down, that action won't be happen. So we have to give the medicine from the outside. So aspergin is a drug. Okay, colony stimulating factor. Aspergin is a drug. So what is the management when we are taking aspergin? See, there might be a chance of seizure. There might be a chance of hypotension. There might be a chance of thrombotic events. Okay, then we'll give the iron compounds. Kindly note here the iron injections. When we are giving the iron injections, if it is a syrup, we'll usually say to use a straw because it will stain the teeth. Okay. When we are giving an IM injection of these iron compounds, Z-track method have to be followed. A Z-track method have to be followed. Why? Because see, suppose this is your skin, this is your muscle. So you have to pinch this skin into this area so that when you insert your needle and when you release it, it will be like this. So that capillary refilling through the puncture which you have made is prevented. That is Z-track method. And vitamin supplements. Okay. So any doubt in the cardiac pharmacology? Guys, any doubt in the cardiac pharmacology? Jinsi, any doubt?